All right, if you're getting ready for the NCLEX, you know there are some topics you just can't avoid. And enemas? They're definitely one of them. So in this explainer, we are going to break down absolutely everything you need to know. Think of this as your high-yield study guide, covering it all, from the fundamentals right up to clinical judgment. So here's our game plan for today. We're going to start with a foundation, then we'll explore all the different types you're going to see. After that, we'll walk through the step-by-step guide for safe administration. Then we'll cover the really critical stuff, complications, hit a rapid review of key exam facts, and we'll wrap it all up with a clinical judgment scenario to put it all together. Okay, let's dive right in with the basics. Before we get into all the details, we gotta build a solid foundation. What exactly is an enema? Why would a patient even need one? And, probably the most important thing for your exam, when should you absolutely, under no circumstances, give one? At its very core, the definition is super simple. An enema is just the installation, or you could say introduction, of a fluid solution directly into the patient's rectum and the lower part of the colon. The whole point is to create a specific local effect, which we'll get into right now. So why do we do this? Well, the most common reasons are to relieve really bad constipation or to break up a hard fecal impaction. It's also a totally standard part of bowel prep before something like a colonoscopy. But it's not just about clearing things out. Enemas can also be a way to deliver specific medications, like lactulose, which helps lower dangerously high ammonia levels in patients with liver disease. Now, you really need to listen up because this is a huge safety point for the NCLEX. If you even suspect a bowel obstruction, or if the patient has what's called an acute abdomen, which just means severe undiagnosed pain, or if you see any active rectal bleeding, an enema is a no-go. It's contraindicated. Giving one could actually cause a perforation. Your job as the nurse is to assess first, and if you see any of these red flags, you stop and call the provider. All right, let's keep building on that. Not all enemas are created equal, not by a long shot. The best way to think about them is like different tools in your clinical toolkit. Each one is designed for a very specific job, and each comes with its own set of risks and benefits. This table here lays out the main categories perfectly. You've got your cleansing enemas. Those are the most common. Now, inside that group, you need to pay really close attention to tap water enemas because they carry a risk of water intoxication, and hypertonic enemas, like a fleet enema, which can cause some serious electrolyte imbalances. For safety, normal saline is almost always the best choice, especially for kids or older adults. Then you have your more specialized types, like oil retention to soften stool and medicated enemas to deliver drugs. Now, what's really interesting about this slide is how it breaks down the key differences. A cleansing enema that uses a large volume of fluid for a really rapid evacuation. An oil retention enema, on the other hand, uses a tiny volume, and the patient has to hold it for about 30 minutes for it to work. And a medicated enema? Well, all the details, the volume, the time, that's all based on the specific drug you're giving. See how the goal completely dictates the method? Okay, so knowing the what and the why is half the battle, but now let's get into the how. Getting the administration technique right is absolutely non-negotiable. It's crucial for patient safety, for passing your skills checkoffs, and for the NCLEX. This is your blueprint. If there is one single thing you remember about positioning, please let it be this. Left side lying, also known as the Sims position, is the gold standard. And this isn't random. By positioning the patient on their left side, you're using gravity to help the solution flow downward, following the natural curve of the sigmoid colon. It just makes the enema way more effective and a lot more comfortable. And here's another one of those crucial areas where the details really, really matter. The administration is totally different based on the patient's age. For an adult, you're going to insert the tip about 3 to 4 inches. But for a child, or especially an infant, that depth is much, much shallower, and the amount of fluid is way less. You have to know these differences to prevent injury and fluid overload. So let's just walk through the process. First step, prepare. You verify the order, you explain the procedure to the patient, and you warm the solution to room temperature. Trust me, cold fluid will cause cramping. Step 2, position them on their left side. Step 3, insert. Lubricate the tip really well and aim it gently toward their belly button. Step 4, infuse. You do this slowly with the bag no more than 12 to 18 inches above the anus. Now, if the patient says they're cramping, just stop the flow for a second. Let them breathe. Then, afterwards, you assist them, you assess the results, and you document everything. Okay, now we have to talk about what happens when things don't go according to plan. Being able to recognize complications is a core nursing responsibility, And it's a huge part of those clinical judgment questions you're going to see on the NCLEX. This slide connects the problem right to the cause. If the patient is cramping, it's often because the fluid went in too fast. We already talked about how electrolyte imbalances are a major risk with hypertonic enemas, right? And water intoxication can happen with tap water enemas. But the most dangerous complication is rectal perforation, and that's caused by forcing the insertion. This is exactly why it is so critical to be gentle and to never, ever force it.
Okay, time to shift gears. Let's do a rapid-fire review. These are the absolute must-know, high-yield facts that you need to lock into your brain for your exam.
Ready? Let's go. Left side lying is best. Never force insertion. Stop for pain or cramping. Oil retention waits 30 minutes. Hypertonic means you gotta worry about electrolytes. And if you suspect an obstruction, no enema, period. To help you remember all this, here's your first memory hook. Just say it to yourself. Left is best. This is for patient positioning. It's simple, it's effective, and it's almost always the right answer on the test. Next up, oil weights. This little phrase reminds you that those oil retention enemas, they need to be held for at least 30 minutes to really work their magic and soften things up. And finally, Fleet steals fluid. This one refers to those hypertonic solutions like Fleet enemas. They work by osmosis, which means they pull or steal fluid from the body right into the colon. That's what makes them so effective. But it's also exactly what creates the risk of dehydration and electrolyte imbalance. All right, for our final section, let's put all this knowledge into action. This is where we bridge that gap between knowing textbook facts and making real-world clinical judgments, which is exactly what you'll have to do on the next-gen NCLEX. So here's the setup. You have an 82-year-old patient who has a history of heart failure, and the order is for a hypertonic enema. Right away, your clinical judgment alarm should be going off. You've got an older adult, a known cardiac condition, and an enema that's designed to shift fluids. You follow the procedure, you position them correctly, and you begin the infusion. But 5 minutes in, your patient tells you they suddenly feel dizzy, and you notice their breathing has gotten faster. This is a classic sign of a complication. That hypertonic solution is likely pulling fluid from their circulation, and it's stressing their already compromised heart. So the crucial question is this: recognizing these signs, what is your immediate priority as the nurse? What would you do next?